When the Federal Office of Civil Rights investigates a healthcare organization for a HIPAA security violation, good intentions are irrelevant. Regulators demand one thing: objective evidence. This table breaks down the results of the OCR's audit program. Notice the vast discrepancy. Tens of thousands of complaints are filed every year, but only a tiny fraction, less than 0.1%, result in formal settlements or civil monetary penalties. The entities that successfully navigate an audit and avoid these severe penalties do not achieve it by having perfect security records with zero breaches. They avoid them by proving they maintain a systemic, structural culture of compliance. Generating this proof means moving past passive observation. An organization has to actively and continuously document the validation of their security measures. To satisfy federal regulators, healthcare entities must architect self-correcting systems specifically designed to produce exact, verifiable records of their security practices. True compliance is a continuous, functioning system, not a static state that an organization achieves and then forgets. The foundation of this system requires distinguishing between two linked concepts: monitoring and auditing. Monitoring is the ongoing, day-to-day assessment of an organization's established controls. For instance, an IT department might deploy systems that automatically track network traffic or generate user access logs to spot suspicious activity in real time. Auditing, by contrast, is an independent, retrospective review designed to prove whether those daily controls actually function correctly. The core goal of the audit is to take that daily monitoring data and validate it against established federal HIPAA standards to ensure the organization is meeting its legal requirements. As an example, while IT monitors the network, the Chief Security Officer would conduct an audit to verify that the IT team successfully identified, documented, and stopped a specific instance of unauthorized access. To generate the objective evidence required by the OCR, covered entities must execute a rigorous, cyclical audit program to constantly interrogate their own monitoring systems. This diagram illustrates the complete audit process as a continuous loop. The cycle begins with identifying specific areas to be audited. Because an organization cannot audit everything at once, selections are driven strictly by periodic risk assessments. Scoping relies on dividing risks into three categories: administrative, physical, and technical. Administrative safeguards involve auditing policies or business associate agreements. Physical safeguards mean auditing hardware access controls, like card key logs. Technical safeguards focus on digital infrastructure, confirming encryption protocols actively secure data. Once a safeguard is targeted, the organization must define the audit typology. Will it evaluate a process, a product, or an entire system? A process audit verifies if employee tasks are meeting established operational standards, while a product audit evaluates whether a specific tool, like a network firewall, is actively blocking malware. Carefully scoping the audit at the outset ensures the organization directs its resources towards mitigating actual, documented vulnerabilities, rather than wasting time reviewing low-risk operations. Returning to the audit lifecycle, we enter the logistical preparation phase. Step 2 dictates audit frequency based on risk. Steps 3 and 4 involve scheduling fieldwork and notifying departments so data is ready. Step 5 prepares the methodology, selecting collection tools and establishing compliance thresholds. Rigorous execution during this planning phase prevents the actual audit from collapsing due to disorganized, incompatible, or missing records. This brings us to Step 6, conducting the audit, which is commonly referred to as fieldwork or data collection. Because reviewing 100% of an organization's activities is a logistical impossibility, auditors rely on strict data sampling methodologies to isolate a representative cross-section and reduce bias. The evidence gathered during this phase falls into two primary categories: qualitative data collected manually and quantitative data captured automatically. This document is an example of manual qualitative evidence. It is a physical training log proving that specific employees completed their mandated security awareness education for the given quarter. Conversely, this chart illustrates quantitative data collected automatically. It tracks the exact volume of audit trail entries generated by software and the subsequent number of security breaches identified and investigated per month. A third valid collection method is visual observation. An auditor might physically walk the clinic floor to confirm that computer monitors are turned away from public view and that mobile devices are physically secured to desks. Following data collection, the organization executes Step 7, recording the findings. All of this collected evidence must be compiled and securely stored. The HIPAA security rule mandates the retention of these audit documents for exactly 6 years. This archived documentation is the only valid defense an organization has during a retrospective OCR desk audit. The final step in the cycle is reporting the results. In healthcare compliance, there is a strict rule. If it is not documented, it did not happen. Audit findings, supported by tables and data displays, must be formally presented to the Chief Security Officer and the organization's Compliance Advisory Committee. The primary objective of this reporting is internal vulnerability management. The organization needs to identify substandard metrics and policy gaps long before federal regulators ever arrive. When an audit reveals that a security threshold has been missed, the organization must immediately initiate a corrective action plan, or CAP. A CAP outlines specific, accountable, and deadline-driven steps required to remediate the issue, which could range from deploying new access technologies to completely overhauling an outdated privacy policy. Enacting a CAP does not mark the end of the compliance process. Rather, it triggers a mandatory reset of the entire audit loop. The newly implemented safeguards and altered metrics must be reassessed and continuously monitored in subsequent audits to prove the CAP was actually effective in closing the vulnerability. Compliance is never a final destination. It is a continuous, self-correcting evidentiary loop, and the only reliable shield a healthcare organization has against severe federal penalties.